Hi, good evening. My name is Norma Nevares, and I will be presenting for Advanced Clinical Practice N5472. This is going to be HMP number 1. A chief complaint: the patient is a 15-year-old female that is status post-auto versus pedestrian. The patient is unconscious with a GCS of 3 and unknown downtime. A donut lac is to the left side of the head with no other visible injuries. For the history, the patient is a 15-year-old female that is brought to the emergency room as level 1 trauma, status post-auto versus pedestrian. The accident was a hit and run and happened approximately at 14:16. The speed limit of the accident area was 35 miles an hour. The patient is a GCS 3 on the scene with blown fixed pupils per EMS. Upon arrival to the emergency department, the patient continued to be a GCS 3 and was intubated. The patient was noticed to be sinus tachycardia in the 130s and hypotensive in the 90s over 60s. A subclavian central line and right radial A line have been placed at this time, and norepinephrine has been started to keep MAPS greater than 65. The patient was taken to CT. CT of the head has confirmed subarachnoid hemorrhage along the flax and tentorium cerebral edema. Pelvic X-ray displays a non-displaced fracture at the right pubic bone at the level of the acetabulum and widening of the right sacroiliac joint. A CT of the pelvis also displays an acute extravagation with a right lipopsoas muscle, right iliac muscle, and right inferior pelvic space, moderate amount of blood in the right lower quadrant, and pelvic fractures through the right sacral joint, right acetabulum, and coccyx. CT of the thorax displays upper bilateral lobe pulmonary contusion and right mainstream intubation. For review of systems, unfortunately, we were not able to obtain at this time due to the patient being the GCS of 3. Upon physical examination, heart rate was in the 130s, systolic blood pressure is 90 over 60s, respiratory rate 14, and Tmax was 37.3. The patient, again, is on ventilation support with 97% FiO2. The patient's height is 165 centimeters with weight of 55 kilos. Upon examination, the patient is not awake, alert, or oriented to place and time. The patient is currently intubated and is not able to follow any commands. The patient has been noted with left occipital lacerations. No facial droop is present. Cranial nerves are not able to be obtained due to the patient being on sedation. The patient's pupils are not equal and are noted to be blown and fixed. Patient's sclera is noted with subjunctival hemorrhage. Bilateral preorbital edema is present with bruising. No deformity is noted to bilateral ears or proportional to patient. Cough and gag is not intact and present when suctioned via the ET tube. The trachea is noted to be midline and oral mucosa is dry. No lymph masses are noted. Carotid pulses are +1. The patient is intubated with minimal respiratory distress. Patient's chest expansion is symmetrical and equal with ventilator assistance. Minimal crackers are noted to auscultation and diminished to the bases. No wheezing or bronchi noted. Hypoactive bowel sounds are present. Patient's abdomen is round and soft with minimal distension noted. Patient has 0 out of 5 strength to the upper and lower extremities. A flag pain scale level is 0 of 10 on sedation, and patient is noted with a +1 radial pulse. No injuries to the right or left upper or lower extremities. No past medical history was attained. No surgical history was attained at this time. Present medications for the patient is albuterol, bacitracin, BID, chlorhexidine for the VAT bundle. Famotidine 20 milligrams, IV piggyback every 12 hours. Fentanyl PCA, Keppra 500 milligrams, IV piggyback BID. Propofol is on a drip rate and it will be titrated to the patient to keep at a comfortable level. And sodium 3%, also IV continuous. Allergies, no known drug allergies at this time. For the patient's social history, the patient does live in El Paso, Texas, where she resides with her mother, stepfather, and siblings. The patient's parents are divorced for several years. The patient is a middle school student with no medical complications. Patient's baseline consists of being able to perform activities of daily life with no complication or assistance. According to the parents, the patient does not use alcohol, tobacco, or illicit drugs, and no history of family cancer. Upon laboratory data, WBCs were 17.22, red blood cells 3.8, hemoglobin 3.12, hematocrit 37.2, platelets 201, PT 11.4, INR 1.4, sodium 138, potassium 4.0, chloride 129, glucose 131, BUN 7, creatinine 0.7. For images, again, as stated before, CT of the head has confirmed subarachnoid hemorrhage along the flax and tentorium cerebral edema. The patient does have a pelvic X-ray with a non-displaced fracture to the right pubic bone at the level of the acetabulum. CT of the pelvis also displays the acute extravagation with a right iliac muscle and the right inferior pelvic space. For the CT of the thorax, it did display the bilateral upper lobes, pulmonary contusions, and right mainstream intubation. As far as assessment, the patients will be for number 1, subarachnoid hemorrhage. A subarachnoid hemorrhage is the bleeding between the brain and the tissue covering the brain. This is for Friedman 2011. The patient is the status post auto versus pedestrian, and the CT results of the head confirmation for the subarachnoid along the flax and tentorium cerebral edema. Number 2, a pelvic fracture is a break of the bony structure of the pelvis, which includes the break of the sacrum, hip bone, pubis, ilium, or tailbone. Complications include bleeding, injury to the bladder, and bladder or vaginal trauma, pelvic X-ray displaced, non-displaced fracture to the right pubic bone level of the acetabulum, and widening of the right sacroiliac joint. Number 3 for assessments would be pulmonary contusions. According to the Mayo Clinic, disease and conditions is bruising to the lungs tissue itself and is most common thoracic injury, especially to kids. A CT of the thorax displayed upper lobe pulmonary contusions and right mainstream intubation. Like mentioned before, upon examination, the patient was noted with minimal distress with intubation, and crackles noted in auscultation and diminished breath sounds to the lower extremities. As far as the patient's plan, the patient is to be admitted to the intensive care unit with neurochecks Q1. Patient is go to the OR immediately with surgery, with a surgery team for abdominal X-lap, packing, and possible ephthera placement. The patient is also supposed to be going to the OR today for embolization. Repair of the left scalp laceration with sutures. Also due to the H&H, we're going to be transfusing 2 PRBCs. Post-transfusion H&H labs. We will be initiating the TBI protocol. Intracranial bolt placement to be placed after all the interventions per neurosurgery team. Continuous ICP monitoring to keep ICPs less than 20. CPPs to be more than 60. No Lovenox to be given. The patient is to be in PO, only to be used, the OG is only to be used for medication administration. Foley catheter placement for strict in and outs hourly. Norepinephrine as needed to keep MAPs greater than 65. GI prophylaxis of famotidine 20 milligrams, IV piggyback every 12 hours. VTE prophylaxis of bilateral STDs are to be placed. For pain control, the patient has acetaminophen 650 milligrams every 4 hours for pain level 1 to 4, fentanyl every 2 hours for pain level 5 to 6, fentanyl 100 mics, IV push, PRN every 2 hours for pain level 7 to 10. Anticonvulsants, we're going to go ahead and keep the Keppra 500 milligrams BID. Continue the sodium chloride at 3% with a sodium goal of more than 150. Propofol standard drib, again, that's going to be titrated. Low dose of insulin aspart every 4 hours. Bowel regimen of Dococet 200 milligrams BID suppository. And family conference if needed to update the patients for a poor prognosis. possible apnea test and brain flow to be performed also, and consult the neurosurgery team for follow-up testing and treatment.